Good afternoon, everyone. It's our pleasure to invite Professor Alan Matsumoto to the stage. Professor Alan Matsumoto is an interventional radiologist. He's the professor at the University of Virginia. He's the previous chairman of the Department of Radiology and Medical Imaging. He's the current director for Focused Ultrasound Center of Excellence. He has special interest at the moment for vascular diseases and focused ultrasound as well. He's the current chairman for the American College of Radiology Board of Counselors, and he's the past president for the Society of Interventional Radiology back in 2016 and 2017. And he has won a few gold medals as well, just like in the Olympic Games here, Professor. Please, Professor, time is yours. Thank you.
Thank you. Good afternoon. Can I ask, oh, good. You switched it to English. Thank you. I can do a little better with that. So I'd like to thank the organizing committee for inviting me to this meeting. I'm very inspired by what I've already learned and heard. I'm also very humbled by what I've learned, particularly that the United States is well behind the rest of the world, and particularly many of the health systems within China, particularly outside the neuro side in terms of applying focused ultrasound therapy for caring our patients. So I've been asked to provide our experience on focused ultrasound for uterine fibroids and breast fibroadenomas, and also talk a little bit about histotripsy for liver cancer. I will say that our experience with focused ultrasound for uterine fibroids is not like the big experience that was in the IDEAL trial that David talked about earlier this morning. These are my disclosures. So what I'd like to do is provide a review of our experience with MR-guided focused ultrasound for uterine fibroids. I would like to talk about ultrasound-guided focused ultrasound for treatment of breast fibroadenomas, and then talk a little bit about histotripsy for the treatment of liver malignancies. So in terms of MR-guided focused ultrasound in uterine fibroids, we published a paper a couple years ago from 8 academic institutions on our treatment of 99 women with symptomatic uterine fibroids. We use in Cytec Exablate 2100 system that uses MR guidance, and it's paired with the GE 3T magnet at our institution. We used the uterine fibroid symptom and quality of life symptom score and looked at it at 6, 12, 24, and 36 months. We looked at the non-perfused volume to total fibroid volume ratio after MR-guided focused ultrasound, and we tried to correlate it with the Funaki fibroid type classification using T2-weighted MR images. Now, for those of you that have are not familiar with focused ultrasound, gee whiz, this is not playing how I'd hoped. So the image here was supposed to show the spine, fibroid, and it shows off to the left in the image the sagittal image of the fibroid uterus. There's a Foley catheter. There's gel in the rectum that we place there to distend the rectum and push the fibroid more anteriorly. The ultrasound transducer is off to the left. It has 208 elements to it, and any one time, based upon how you set the treatment, it can turn off 25% of the ultrasound transducers. So that comes into the 3D treatment planning. Again, the region to be treated and the sagittal image to the right and the coronal image is on the left are in green, and you can use structures to be avoided by drawing circles or lines around them, whether it's the pubic bone, the bowel, and using this technique, the ultrasound algorithm will eliminate up to 25% of the transducer beams because they come in as a cone, so they won't go through some of the structures where you have the line set up. So that's helpful to minimize treatment complications. You can also use fiducial markers both in the sagittal plane and the coronal plane to watch and see if the uterus or the patient moves during the procedure. Now, during the treatment, you can do temperature mapping and MR real-time thermometry, and you can see in the upper panel, that's the area we're treating. In the temperature curve, you can see over about 25 seconds, the temperature gets above 75 degrees Celsius. Our goal is to get to 65 degrees Celsius for at least 1 millisecond. And image 2 shows you the penumbra area that the temperature does rise. It got up to about 55 degrees. That's in the area immediately adjacent to the area treated. And then when you get about 7 millimeters away from the area, you can see the temperature stays relatively low. So one advantage of MR-guided focused ultrasound, you can do thermometry at real-time treatment. So here's a patient that we treated. You can see the areas that we wanted to treat there on the left. Post-treatment, we had a little bit more than 94% non-perfused volume. Now, when we looked at our data and time after treatment, you can see the uterine fibroid quality of life symptom severity score on the y-axis, and on the x-axis, you can see that their symptom score was around 70 on average, and post-treatment, the symptom score fell to 20. The lower the score, the fewer the symptoms. Here are a couple examples from the treatment. The upper panel are the non-responders where there was a very low non-perfused volume. The middle panel is sort of a medium level of non-perfused volume. These two patient populations end up being non-responders. The bottom is what we call a responder and a high non-perfused volume compared to total fibroid load. Now, when we look at the ratio of ablated volume to total fibroid volume, you can see that the ones that do the best have greater than 80% non-perfused volume. And if you break them out based upon the Funaki score, the type 1 lesions, those that are low signal on T2 images, they're the gold bar. You can see the score, symptom severity score, goes low and stays low in comparison to the type 2 and type 3 Funakis that are inhomogeneous or mixed signal. And these are examples of the Funaki type 1, type 2, and type 3, where you can see the type 1 is homogeneous, low signal on T2 weighted images. Those respond the best. In terms of our complication rates, the most common complication rate was our urinary tract infection, probably related to less than optimum placement of the urinary bladder catheter. We saw skin burns. This is an example of one of my patients that in a scar from a prior appendectomy, she did not feel a thing, but when she got off the table, this is what we saw. This healed, but it took about 6 weeks for it to heal over time. We also had one acute bowel perforation as part of this trial. I think this is my old set, not the one I gave to you earlier, but I'll just go ahead and go with this one anyway. This is our experience with the ultrasound-guided focused ultrasound and breast fibroadenomas. My two colleagues, John Wynn and Carrie Rockman, who are breast imagers, really led the study. It was an FDA IR-approved study, started in 2014. It was a single-arm study where we treated 20 patients. The primary objective was to evaluate feasibility for tumor response, patient experience of treatment, and safety. Now, for those of you that are not familiar with breast fibroadenomas, they're benign fibroendothelial breast tumors. They're not malignant. The incidence is about 10 to 15% in women. They're most commonly in young women, ages 15 to 30. They present as a mass, oftentimes with pain and tenderness, and they can change the breast contour on observation. There's a craniocaudate MR. You can see the fibroadenoma on the left, and you can see the pathology specimen on the right. A lot of colloid and fibrous tissue. The typical management is to observe them, but when they become symptomatic, they often undergo surgical removal, which leaves a scar. So the idea of using ultrasound-guided treatment was entertained. The unit that we use was a unit from France, Thoracleon. This is an echo-pulse technology. It has an extracorporeal robotic probe mounted on an arm and moves by motors. There's a cooling unit and an ultrasound imaging transducer manufactured, as I mentioned, in France. This is what it looks like. There's the fibroadenoma, pretty homogeneous. This is a medium-sized one, probably about 3 centimeters in size, and that's what it looks like when you turn the focused ultrasound under ultrasound guidance. And then post-treatment, you see the bubbles within the lesion with increased echogenicity within the lesion. What we saw is a change in volume in the fibroadenomas between 0 and 12 months. All fibroadenomas decreased over that 12-month period. The mean volume shrinking was about 64%. It ranged anything from 7.7% to almost 97%. And you can hear is what you see at follow-up. This is a breast ultrasound at time 0 pre-treatment, and at 3 months, there's about a 69% decrease in volume. If we look at the patient's symptoms, all of them had a palpable mass, all 20 had a palpable mass pre-treatment. 78% of them had no palpable mass at 12 months. Half of them, the mass was painful. None of the ones that were available for follow-up were painful at 12 months. And this is what you can see pre-treatment, post-treatment, smaller, more echogenic, and this one decreased about 70% in volume. Now the next technology, in terms of the safety data, there was no serious adverse events, no skin burns or persistent skin changes, no persistent pain. There were a few minor events. There was some ecchymosis, likely related to the local lidocaine, because it is painful, so we give a little lidocaine pre-treatment. There was some edema post-treatment. There was pain in 8 of the 20 patients, although it was very mild, and none of the patients had any pain, residual pain, at the 12-month follow-up. Now, what I'd like to do is talk to you a little bit about histotripsy and liver malignancy. The unit that we use is histosonics. Now, it was FDA approved in October of 2023. We had hoped to get this unit into our institution by January 2025. We didn't get it until May of 2025, and we just treated our very first patient using this technology 12 days ago. We have other patients lined up, but it uses not so much heat, but cavitation to disrupt the tumor. And the principle is that it liquefies them without destroying the proteins, and potentially, if you use it at the right energy, you can leave the antigenic proteins that your immune cells can pick up on the tumor antigens and yet have the tumor itself die because you're not using heat. So you do not get denaturation of the protein. It has precise focus. You can see the area of destruction and the reserve viability, and that transition zone is very narrow in terms of a few millimeters. And what's very interesting about this technology, because it uses cavitation and not heat, and the proteins are not denatured, it appears to not disrupt collagen. So there is tissue selectivity. So within the liver, it doesn't affect or injure the bile ducts or the blood vessels. And it has been used to treat liver tumors that have invaded the portal vein and hepatic vein. You can also treat patients that have biliary stents in place without adverse effect. This is an example from the Teresa trial, again, because we have not developed experience as much as we'd hoped by the time this meeting came about. This is an example where there's the baseline, small localized hepatoma. You can see post-treatment that there's this larger area, there's some swelling edema. At 30 days, you can see the lesions retracting. It's not enhancing. 6 months, it's regressed, and 1 year later, it's not enhancing, and it's even smaller. There's a 95% volume reduction at this point. Now, this paper they looked at and they published about what types of lesions and what segments of the lesion can you treat with this technology, and typically the areas that you can treat within the liver best are segments 3 through 6. And if you look at that, it's sort of in these areas that are green and blue. And as you get near the dome of the liver, it's harder to treat because you have to start treating through the lung. You have to treat through the rib cage, which makes it tougher to get into. You can get close to the heart. And if you get too close to the liver capsule, you can cause quite a bit of pain. So of this 460 patients that they treated, probably about 80% that they treated were in this green to blue zone. Tells you that there are some limitations in using this technology. Now, because we don't have enough experience, this is a case that Dr. Roberto Hernandez Alejandro allowed me to use. He's a chief of Transplant Institute at University of Rochester in Rochester, New York, and he was one of the first purchasers. So this is his first patient that he treated in November of 2023, 1 month after the technology was FDA approved. Now, if you look at the yellow area, that was the lesion treated, okay? At 30 days post-op, you can see that lesion smaller. But interestingly enough, this patient was treated for some discomfort and pain. It was for palliation, not for cure. You can see the other lesions that were not treated on post-op day to post-op 30-day have shrunk. Similarly, if you look at the CEA, at the treatment on November the 1st, 2023, the CEA came down, even though he only treated that single lesion up in segment 2, up there. So anyway, it's very interesting. Now, there's a user group in the US. Now, we've treated about 750 patients in the United States on label through the FDA liver tumors, and other folks have reported an abscopal effect. About a month ago, a patient with metastatic cholangiocarcinoma of the liver, metastatic to the lung, they had 3 months of follow-up, and the lung lesions shrunk after they treated the liver lesions. Now, this is anecdote. There's no papers out about this. In our user group, we're seeing an abscopal effect. Now, whether it's monotherapy, histotripsy alone, or combined multitherapy with microwave, immunotherapy, chemotherapy, or radiation, the company has established another trial that they're going to enlist. It's called the Boombox trial, where they're going to have 5,000 patients enrolled, and they're all liver types, primary hepatoma, metastatic lesions to the liver, and whether they're on other therapy or monotherapy, and then try to tease out all that data to see outcomes based upon that. So they just enrolled their first few patients in this Boombox multi-center. It's like a registry to better understand this technology. Now, in this Hope for Liver single-arm pivotal trial that was published in 2024, at that time, this is the trial that led to the FDA, data from the FDA trial that led to the FDA approval in October 93. They had a 95% technical success rate in treatment of the targeted tumor volume. They had a 6.8% rate of complication, defined as index procedure-related adverse event. In our single patient we treated, they had a little erythema at the skin site that we treated. It was a metastatic neuroendocrine tumor that had failed other therapy. She had some pain for 24 hours post-procedure. We kept her in the hospital overnight for an octreotide IV infusion for 16 hours. She went home the next day. At the 1-week follow-up, she was doing fine, had a little discomfort, probably over the rib. She probably has a little periostitis because we had to treat through intercostal approach. But the most frequently reported non-serious adverse events were abdominal pain, procedural pain, and some pyrexia. That probably has some tumor necrosis, pyrexia. The follow-up data from this, we now have the 12-month data from the HOPE trial, and all 90% of the patients treated here had tumor, not regression, but stability. And so the other data that's showing is that, at least anecdotal and is coming up for publication, is that it depends upon whether you're treating for cure or for palliation. And a lot of patients are being treated for palliation. You've seen patients be treated with biliary obstruction, and you go in and treat the tumor, and you can treat the tumor so it shrinks enough that their biliary obstruction relieves. And so you can obviate the need for them having an externally draining biliary tube. So it's proven to be, at least anecdotal, have multiple applications above and beyond tumor destruction. So that's a short overview of focused ultrasound for uterine fibroids and fibroadenomas at our institution. A little brief overview of histotripsy in the US for liver cancer. At our institution, we've only treated 1 patient to date, and in the US, we're up to the user groups about 750 patients, and we meet once a month to talk about interesting cases and what we've learned, and we even talk about some of the complications that we've run into. So thank you very much.
Thank you, Professor Matsumoto. Thank you for your nice extensive presentation, especially about the histotripsy for liver cancer. It's a very nice topic especially for gynecologists. We are hoping, I guess, in the future with AI, hopefully with the ultrasound guidance HIFU, that we can check the temperature just like the MRI guidance HIFU in the future. Thank you.